Hi, everyone. Welcome to our webinar today. I'm just waiting for a few guests to join us, and then we will begin shortly. Okay, today we're going to start our webinar off with a few patient testimonials. We have some brave ladies who have agreed to share their story with you. I will be starting off with a lady by the name of Madeleine, and I'm going to welcome her to let you know what her experience was with the microsurgery. Hi, Madeleine, welcome.
Hi ladies. So yes, I'm in the bus. I'm the first one, but I had plenty of pain just after my period, and then Corin advised me I must come and do the surgery. So the surgery went very well. I was very scared to do it, and so it went good. I was done late that night, but the night was good. After that, it was terrible pain. I won't desire anything about that, deny and tell anything. No, it's very fabulous. It was the pain I can't describe. But after that, I can assure you it was wonderful. Everything after that, just good. The team there is wonderful as well. We had a couple of chats after the operation. Dr. Gary was there himself. He checked up on me. Dr. Corin was there. Even Morgan, the one who answered the phone the first time, he checked up on me. So after that, the experience for the aftercare from these ladies and the gentlemen there is fabulous. So I can't advise anybody who's got that pelvic pain, who's unsure about everything that's happening in their cycles and everything. Speak to these people, and for sure you'll be out. Thank you.
Thank you, Madeleine. Next, I am going to invite another lady, Njabulo, to join us, and she's going to share her story with us.
Hi, everyone. Am I audible?
Yes, I can hear you.
Okay, that's fine. Good morning, everyone. Yeah, I also had a very positive experience. I do want to say that I was also quite scared because there's a lot of stuff that is being said about the procedure on the internet, from people and Facebook. And so I'm not going to lie and say I was not scared to do it. For me, it was unfortunately, I think, one of the best options for me prior. Me and my gynecologist had discussed that, although there are many other options for fibroids, this one was the best for me because my fibroids were like huge, and so even other options were not. So I felt a bit bummed that I have to select this one that seems so scary. But like Madeleine said, the team is at microsurgery. They are really reassuring. They are professional. They give you information. I was a bit skeptical because I found them from the internet, and I was just like, how honest can people that you find on the internet, be? Especially people who advertise themselves so much. You feel like they're probably just fishing for clients, but no, they really care about you. So I've had the procedure. It's been about 22 days now, and I didn't experience so much pain, I must say. So I think our bodies differ, and I'm really grateful to God for that. I did get all the pain meds and everything else, but I think my body just didn't. I know when the physician came, he couldn't believe it. I felt the cramping, but it wasn't as severe. And when I mean it wasn't as severe, it just wasn't. So I cannot obviously tell how the next person can feel, but I will say that for me, whatever I got, I really appreciated the pain pump, the morphine, and everything else, and I think it just worked out, and our bodies respond differently. I prior to that had a bowel obstruction, and the doctors didn't really know where it came from. And I do want to say that I had seen my physician before the procedure now with microsurgery, and he was like, listen, you will feel so much better after your embolization. And he was absolutely right. I don't know obviously yet that it has solved everything, but my tummy is flatter, softer. My diet has improved. The operation has just done so much more than just relieve me from the fibroid pain and mess and heaviness that I felt before. And so it's been overall a very positive experience. And I would really encourage anyone who wants to do it and thinks that this is the best option for them to go for it, because it really does work. Thank you.
Thank you. Thank you, Njabulo, for sharing your story. Okay, we are going to continue now. I will tell you all about fibroids. So let's talk fibroids and a uterine artery embolization, a minimally invasive treatment option. What are fibroids? Fibroids are benign growths. So benign means not cancer. They grow in your uterus. They consist of smooth muscle and fibrous connective tissue. They're also known as myomas, leiomyomas, or even fibromyomas. Where do they grow? So they grow in the uterus, and they can grow in numerous places. They can grow in the muscle of the uterus, what we would call an intramural fibroid. They can grow towards the outer surface of the uterus, known as a subserosal fibroid. Some of these can grow further out of the uterus, and then they just grow on a little stalk, and then they're known as a pedunculated fibroid. They can also then grow closer to the lining of the uterus. Then they're known as a submucosal fibroid. And these two can also then grow out onto a stalk, and they would be a pedunculated fibroid, and they would sit right in the middle of the uterine cavity. What are some of the symptoms that fibroids cause? So often ladies don't have symptoms, and they just find out that they have them when they go for a routine gynae checkup. But some of your more common symptoms are back and pelvic pain, abdominal pain, a large abdominal mass. You could have very heavy and very painful periods. You could have pain during sex. You could be constipated, a lot of bloating, especially if the fibroids are sitting on your intestine. Or they sometimes might put pressure on your bladder, and this might give you the need to go and wee frequently. And they can also affect your fertility and pregnancy. So what causes fibroids? One of the known causes is our hormones that we produce each month with our normal menstrual cycle. So normally with your period, you produce estrogen, and around day 14, your estrogen peaks, and this coincides with ovulation. And estrogen actually feeds fibroids. It makes them grow. Then there's also a genetic link. So if in your family, your mom, your aunt, your granny, your sister had fibroids, then the chances are you will also have fibroids. It does seem to affect particular populations. So if you're of African or Caribbean descent, there seems to be a predisposition for fibroids in those populations. And then pregnancy can also affect fibroids. And the main reason is during pregnancy, you produce much higher levels of hormones. So if you already have fibroids, it can make your fibroids grow very quickly, or it can trigger them to start growing. So who's at risk of developing them? Usually ladies over the age of 30 are more at risk. If you have a family history during your pregnancy, if you're of African descent, and then also being overweight. The reason being overweight puts you at risk of developing fibroids is the excess adipose or fat tissue that you carry when you're overweight produces estrogen. And then again, the estrogen feeds the fibroids. How are they diagnosed? So like I said, it could be an incidental finding. You go to your gynae for your routine checkup, they do an ultrasound and they see, oh, you have fibroids. Maybe you present to the emergency department with lower abdominal pain, they do a scan to see why, and they find that you also have fibroids at the same time that you maybe had appendicitis. It can be diagnosed on ultrasound, and then we can also see it on MRI. That is actually our preferred method of diagnosing fibroids, but they can also be seen on things like CT scans. What are your treatment options? So you can start off with medications. Medications could include something like the oral contraceptive pill. This usually helps with the symptoms of fibroids. It doesn't necessarily treat them. It doesn't make them smaller or go away, but it can help to control the bleeding each month. There are medications you can take which actually block your estrogen, and this will make the fibroid shrink, but they also have a lot of negative side effects, like they can cause severe osteoporosis in young women. It's like we force you into menopause early. So usually used in older ladies or in ladies who urgently need to shrink fibroids. Maybe you're waiting for an embolization. Then you can go on a short course of that medication. Then there's also surgery, the more traditional way of removing fibroids. So you can either just remove the fibroid itself. This is known as a myomectomy. Or you can remove the entire uterus or womb. This is known as a hysterectomy. Or there are minimally invasive treatments. And this is the treatment that we offer. It's called a uterine artery embolization. Who should consider having a uterine artery embolization? Well, if you're young, it's a good option for you. If you do not want to have surgery, if you still want to have a family, if your previous treatments have failed you, and then we can also do it for high-risk patients. So patients who are not fit to undergo major surgery or a general anesthetic could benefit from our procedure. When is it best to perform a uterine artery embolization? We like to do it when you have symptoms. We don't just want to embolize your fibroids. We want to improve your quality of life. So if you don't have symptoms, then you can do a wait and watch approach. However, when you become symptomatic, that is a really good time for us to do the embolization for you. The embolization can also treat another condition known as adenomyosis. This also causes excessively heavy and severely painful periods. And the same procedure that treats fibroids can treat adenomyosis. We can use it for dysfunctional uterine bleeding. So maybe you don't have either fibroids or adenomyosis, but you have excessively heavy periods. The gynae's worked you up. They can't find out another reason. We can do the embolization for you to see if it doesn't help. We can do it before you have a myomectomy. Now, the reason we would do this is maybe you have 5 fibroids, but one of them is growing on the outside of the uterus, like I said, on a stalk. It's really big. And so to actually surgically remove it is going to give you a very good result. But then you've got 4 other fibroids growing within the muscle of the uterus, and surgically it's just too high a risk to remove all of them. So we could do the embolization first, and then afterwards you could go and have that one big fibroid removed. And the great thing about doing it this way is because we've embolized, the blood supply to that fibroid has been cut off. And so when the gynae does remove it, you bleed a lot less during the procedure. We can also do the embolization for someone who's injured their uterus. Say you've been in a car accident. We can do the embolization just to stop the bleeding so that you don't need to have a hysterectomy. We can do it for ladies who just continue bleeding after giving birth. And then also for palliative reasons. So say if someone has a large cancerous mass, we can embolize it to shrink it just to give them some relief from pain. So how do you book a uterine artery embolization? This is where we come in. You contact an interventional radiologist. We will help to set up an appointment for you to see a gynecologist. The gynecologist will do some basic investigations, like if you need to have a pap smear, they'll do an ultrasound for you, and they'll just make sure that everything else is, that you're in good health everywhere else, and then you can come to us for the embolization. You'll have some blood tests done. We would send you for an MRI. Now, even though the gynae does do an ultrasound when they see you, you can't always see all the fibroids on ultrasound, and you're not always able to see adenomyosis on an ultrasound. And so that's why we choose to do the MRI. It's the gold standard, and it allows us to see all the fibroids. We know the exact location, the size, and then if there's adenomyosis, we will also be able to see it on the MRI. We will then arrange for you to be admitted to hospital, and you'll meet the team. What are the benefits of having an embolization? So it's minimally invasive. We do it through a needle point entry in your wrist. It's done under sedation, so you don't need a full anesthetic. You'll be fast asleep during the procedure. You won't feel any pain while we're doing it, but you will still be breathing on your own. It has a much lower complication rate than your surgical options. You have a much shorter hospital stay. You will have no scar after the procedure. So I know there's a lot of stigma around ladies who have big scars on their tummies. And in some cultures, certain men might not even choose you then to be their wife if they see you have the scar. So with us, there's no scar. No one will need to know what you've had to go through. And because we don't make any large incisions or even small incisions, we have a much quicker recovery period. So how is the procedure performed? So we give you a sedation where you sleep, but you still breathe on your own. It's done in theatre, and we do it in a special theatre that has machines that can give us imaging while we're doing the procedure. We then use an ultrasound to find the artery in your wrist, the blood vessel in your wrist that we're going to put the needle into. And then through that hole in your wrist, we put catheters and microwires. So these are long, thin plastic tubes that are flexible and soft, and they travel through the blood vessels in your body until we reach the blood vessel where we need to embolize. We use real-time imaging to help us guide the wires and catheters to the right place until we found the uterine artery. That's actually a lovely picture there, Gary pointing at the uterine artery, and that's our goal. We want to get our catheter into that single artery, and once we've isolated it, we can then start embolizing. We use tiny little particles. You can almost think of them as perfect little round beads. We inject them into the uterine artery. They then travel along the artery into the smaller blood vessels, and they cut the blood supply off to the fibroids. The fibroids are then starved of oxygen and nutrients, and this process does cause pain. But at the microsurgery, we perform a nerve block for you. So just above your belly, just below your belly button, we'll put in a long needle, and we will inject a local anesthetic around a group of nerves that supply the uterus. This is all done while you're under the sedation, so you don't feel us giving you the injection. But when you wake up, you will have a plaster below your belly button, but you can be reassured we haven't cut you there. There are no stitches. We've just given you an injection to help manage the pain. We then remove the wires and the catheters, and we put a little compression device on your wrist. It fills up with air, and we will remove a little bit of air over a number of hours. And by the time you go to sleep the night after the procedure, the band will be removed from your wrist. And then you get to take your life back. So if you give us 1 hour to do the procedure, 1 day to stay in hospital, 1 week to recover, then after 1 month, when you have your next period, you will have your life back. You will have confidence. You will be able to go out in public, attend functions, go for a braai, maybe just lie on the beach for the day. But you will be able to do it with confidence and enjoy life as you should. Thank you. We are going to open up the floor now for questions. If you have posted questions in the comment section, Gary will join us now to answer some of your questions.
Hi, Karen. Thank you for your presentation, and thank you to everyone who's involved, giving up your time during the day to have this discussion. Obviously, it's an information session where we're trying to give people an opportunity to ask questions and to understand their options. We're often asked why I haven't heard about this thing, why have I not been told about it, why has my gynae not been told about it? And this is really an active attempt at communication. So as best we can, we're going to try and answer your questions. Some of these questions are quite detailed, and it's not going to be possible to give a direct answer, so please forgive me. I'm going to do my best. What we are offering is a long-term, meaning we've got many years of data. That would be 5, 10, 15 years of data on how this procedure affects women internationally. It's absolutely standard of care. It's paid for by medical aids, and it's extremely well established as a treatment option. It's not perfect for everybody. We need to select the right patients, and that's really our job. But what it is really a much less invasive treatment option for uterine fibroids. And just to understand that all fibroids don't have to be treated. Most women get away with pain medication or iron supplementation, but eventually a large number, perhaps half of women with fibroids, do need some sort of intervention, and this is an option. So I'm going to see what I can do about the questions, just to gathering them together so that I answer as many as possible. Do they come back? Well, the answer to that question is it depends what procedure you had. If you've had surgery, then the chance of the fibroids coming back is quite high. That's about half of women at 5 years will have recurrence. That's not to say the fibroids have come back, but rather the small fibroids that were there before have continued to grow. And the chance of them coming back or regrowing after embolization is much, much lower. It's about 10% at 5 years. So the short answer is yes, they can recur. We can sometimes have to repeat the procedure, but it's much lower chance of that after embolization than when compared to surgery. Can your eyes be open? Yes, they can. There's no pain at all during the procedure. Most of our patients prefer to be asleep, and that's what we do. It's sedation, it's not ventilation, but as you literally just, eyes closed asleep and then wake up and it's done. But you can be awake during the procedure. Can you conceive with fibroids? Yes, that depends where the fibroids are located. Many, many women conceive with fibroids, but it is a large cause of infertility if the fibroids are in the cavity. Can you conceive after embolization? Absolutely. We've got many women who've had babies after the embolization. So to discuss the bleeding going back to normal, well, that was a little confusing, the question. It depends what normal is. So I seem to understand from the question that, you're just having to use panty liners and that's not normal for you. Many women would be happy with that. Some, perhaps the bleeding is a bit less than you expected. Most of my patients are very happy to have less. But the answer is it usually goes back to normal. It does depend on how you define normal, and that's really how it affects your life, I think, is the best kind of definition for normal. So if your period bleeding isn't affecting your life, meaning your iron isn't very low, it's not changing your quality of life, well, then that would be normal for you. So the short answer to the question is it should take about 2 or 3 months to go back to normal. It would be much lighter than most women, or most rather patients have experienced for years, and they're very happy with that result. Jacqueline, fibrothecoma, that's a very specific question, and I can't answer it at this time. Does require investigation, as you pointed out, biopsies and so on, and I don't think this procedure is appropriate for it. But we'd be happy to answer questions more directly if you contact us. How much does it cost? Well, it's almost free if you've got medical aid. So that's the catch. It is available at government hospitals, but in a very limited way at the teaching hospitals in the big cities. For patients on medical aid, it's available. Almost all the medical aids now pay for it. It is a prescribed minimum benefit. Can we do a session on blocked tubes? Good question. Different question. That would be a procedure we do called fallopian recanalization to open blocked fallopian tubes, and we'd be happy to do a separate session on that. We do a lot of those and have great results. Names of medication. I'm not sure how to answer that question. The medication, I presume that's the product we use to cause the embolization. The name of that product is Embozine or Embospheres. We also use a product called Contour. These are all produced by big international manufacturers. I'm not sure if that's helpful, but that's the answer to the question. Can the fibroid be taken out? Mine's about 10 centimeters. Well, again, that's not what we do. So we don't actually take the fibroid out. The fibroid stays inside, but it shrinks significantly. More importantly, the symptoms disappear. So if the fibroid's very big and it's causing a lot of symptoms, it gets smaller, symptoms disappear. You don't really need to take it out. If it does need to be taken out, and this lady described it as a transvaginal. Yes, we often do shrink the fibroid with embolization so that it can be taken out through the vagina, which is a much smaller procedure. actually a huge advantage, but it would be a two-step process. We would do embolization first, wait for the fibroid to shrink, and then the gynae removes the fibroid. What are the long-term effects? Well, that's the point is we're trying to help people, so long-term effects are good. There are some patients who experience complications. Our complication rate's about 1 to 2%. That would be patients who come back within a month, but and that's quite low for any medical procedure. As far as long-term effects, you simply expect a better quality of life. 92% of our patients after 5 years are saying that they're incredibly happy with the procedure. They're happy they had it done and it's changed their life for the better. Discharge after the procedure. This patient describes a discharge after a year. It's quite unusual. We do sometimes see a discharge going on for a few months, but I wouldn't expect a year. So please come back and chat to us. I think maybe necessary to do another scan. Mostly there would be absolutely no experience of this complication. So I'm just wondering what exactly happened, and please chat to us at the hospital. Okay, so yeah, I would expect that's 2-3 months discharge to go away. And it's not smelly, not offensive, just goes away by itself. It's really like a mucus discharge. So
I see there's a question about the fibroids coming back.
yeah, and so I think this is a type of thing.
What to do if they come back.
But
So
in Singh, we haven't had in Singh as a patient. I'm not sure what she's experienced or who did the procedure. So it's quite hard to answer that question without the information.
But maybe just to, I think sometimes what I've seen when doing the follow-ups is often ladies go back to their gynae for their 6-month follow-up, and then they're told that they still have fibroids, and they're almost surprised. So just to clarify, the uterine artery embolization does not remove fibroids. It stops the blood supply to your fibroids. So without oxygen and nutrients, your fibroids shrink and they become much smaller, and the symptoms that they were causing improve. So our goal is to take your symptoms away, improve your quality of life without you needing to have surgery. So even if you went for an ultrasound in 2 years' time after doing the embolization, someone might tell you that you still have fibroids, but as long as they're not giving you symptoms and they've shrank and they're not growing, then we have achieved what our goal was. So it is, you will always have them after the embolization, but they should be smaller, and the symptoms that they were causing before the embolization should improve.
Yeah, absolutely. Thank you for that, Karen. I'm just going to pick out a few more questions. So how much does it cost? So the treatment is covered by medical aid. If you're not covered by medical aid, I would think it's going to be over 100,000 rands, but it really does depend on product that's used and where it's done and so on. So it does vary patient to patient, but again, covered by the medical aid. Natalie, thank you very much for the encouraging words.
I think here's a good question, Gary. This lady's asking if it's safe to have the procedure done when your hemoglobin is low.
Oh, very good question, yeah.
Yeah, I think that's a great question. So sometimes your hemoglobin can be low, but because you've lost the blood over a long period of time, your heart rate is still normal, you're not short of breath, and so you might just be tired because your hemoglobin is low. Then we would be happy to do the procedure for you, because the procedure is going to stop you bleeding heavily each month. And then once we've stopped your heavy bleeding, your iron stores will go up again, and then your body will be able to make more blood. And then you're going to start to feel better. The only time we wouldn't do the procedure when your hemoglobin is low is if it's dangerously low. Your heart rate is high because you've lost so much blood, you're short of breath, then we first need to optimize you before the procedure. But we can do that with the assistance of a physician. We do work with some really great physicians at the hospitals we do the procedure at. They will assist us in optimizing you before the procedure. And then once your heart rates come back down to normal, you're no longer short of breath, we would be happy to do the procedure for you. The other thing to remember with an embolization is it's something that can even be done in emergencies. So even if your hemoglobin is extremely low, but you continue to bleed, we would be happy to do the procedure for you as an emergency, because then it would save your life. I hope that answers your question, Alice.
Okay, so from Fatima, if the fiber is not taken out, it can grow back on 55 in menopause. Sorry, I posed the question earlier. Gynae suggests a hysterectomy on the belly as a vagina, require urologist during surgery as far as close to urethra. Can the embolization be done if my case is complicated? That's actually quite a very specific case. And the short answer is I think we should think about it. There are quite a few sort of issues you've brought up here, Fatima. The issues of menopause, hysterectomy, and then it being it's not a normal kind of run-of-the-mill hysterectomy. The gynae is expecting some complications, as is the fibroid impacts on your urethra and the cervix. So the answer to your question is that we do a lot of embolizations before surgery in order to restrict the blood supply to the uterus, which would make the procedure easier for the gynecologist in some cases. The question of doing embolization in women who are menopausal, that's a little bit more complicated. We wouldn't want to do it for a patient who's got postmenopausal bleeding, because we're worried that there may be a cause that simply a cancer is a postmenopausal bleeding is a red flag for cancer. And therefore we would be a little bit more cautious. But I think in your case, it would be a matter of sitting down with your doctors, figuring out if there's any advantage to doing embolization before. It's a good question. Occasionally I have done this, but it's not a common reason for embolization. Does sound like there are going to be a few doctors involved in your case, though. Regarding heavy iron, very low iron. So we have dealt with that. Apologize. When to do the procedure, I think in terms of the fibroids getting larger and larger, that again is, I think, quite subjective. So some women, watch their bellies get bigger and bigger over time and don't really do anything about it. And some are very self-conscious, and people are going up to them in the streets and congratulating them on appearing pregnant, and it's very embarrassing. So it does depend on every patient, but you need to understand the longer we wait, the bigger it gets. There's only a certain amount of shrinkage that's possible when not removing the actual fibroids. So we expect about 50% shrinkage, as Karen pointed out, about half the size of most women. That's absolutely fine. They're happy with that result. But if you want the fibroid to be absolutely gone, or the fibroids are incredibly large, then we would have a more, sort of moderate result. Karen, have you seen any other questions?
Yeah, there's actually a lady here asking Chinolo. Good morning. I'm from Botswana. Have you had a patient from Botswana who was using medical aid? And the answer is yes. We have helped many ladies who live in other African countries, even ladies who live in Europe or the United States. We do work with international medical aid. So please feel free to contact us and we can help set it up for you. I'm trying to see if I see any others.
Okay, an opt to remove fibroids. I think we covered that. So that's the case that many women who have had surgery and have experienced the fibroids returning. That's quite common after myomectomy, which is the surgery. It's much less common after embolization. Unfortunately, yes, there's no guarantees at all. I can only give you likelihood. It's about 10-12%, depending on the age of the patient and the size of the fibroids, but they recur much less frequently after embolization. Does this help unblock fallopian tubes? No, not well. It depends. If the fibroids get smaller, then the tubes can unblock themselves. We do sometimes see that, but it's a little sort of unpredictable. And considering its fertility, I'd prefer to do an investigation for the tubes rather than just say we've done embolization, therefore the tubes are going to unblock. We may have to actually unblock them. And then I don't want to be under sedative. I want to be awake during the surgery. Please advise. Yes, quite possible. It's not painful during the procedure. Just a little bit annoying or uncomfortable. You just have to listen to my jokes. But the rest of the procedure is fine. If you don't want to be asleep, you don't have to be asleep. That's absolutely fine if you're fearful.
Here's another one, Gary. I don't know if you could. How long after
the procedure can you get pregnant? Good question. Do you want to go with that one?
So our current recommendation is to wait 5 months, just to give your body time to heal. I do remember last year, Gary and I attended a seminar with gynaes who are fertility specialists specifically. They were happy to say you could fall pregnant straight away, according to the newest guidelines. But at the microsurgery, our advice is 5 months after the procedure, we're confident that it's safe for you to fall pregnant.
Yeah, and it's just really a guess at safety. This is very little real medical evidence, but it just seems sensible to let the uterus stabilize. Although experiencing a uterine rupture or emergency after pregnancy after embolization is very, very rare. And then what I do, what would cause the symptoms to persist after a month? Okay, after a month after embolization, I'd really be cautious doing anything because it's really not time to judge it if things have gotten better or worse. It's all stabilizing. Once we've finished the procedure, we're absolutely certain that we've done the most we should have done at that time. I would just wait a little bit, just be cautious. Don't respond to everything.
Here's another one. So this is the same lady who was asking about the pregnancy, so possible complications relating to fertility. So fertility is a very complex issue. There's many factors that contribute to fertility. It's not only whether you have fibroids or not, but do you have healthy ovaries? Does your partner have healthy sperm? Do you have fallopian tubes that are working? But if fibroids are the only issue affecting your fertility, I suppose the most common question ladies ask me is, does it affect your ovaries? And the procedure can affect your ovaries. There's about a 3% chance that you can go into early menopause. The chance is greater the closer you are to menopause. But during the procedure, we do what we can to protect your ovaries. Usually your ovaries get a completely separate blood supply from your uterus. And the artery comes off from much higher up, somewhere around your kidneys. And then the artery supplying the uterus comes from low down in your pelvis. Sometimes the artery supplying the uterus gives off a little branch to the ovary. And we always look for this. And if we see it, we bypass that little branch so that we don't send particles to your ovaries. So we do keep this in mind when doing the procedure. And then also just to keep in mind, if you need to have your fibroids treated for fertility, your options would really be an embolization or a myomectomy. And now whether you did an embolization or a myomectomy, the chance of your ovaries failing is still there. And it's about the same. I hope that helps to clarify that for you a little.
And then just a vote of confidence from Ntombi Futi. Thank you for the very kind words, and it's wonderful after 5 years you've had or rather, Ghani said it's okay, but you're doing great. So that's really encouraging. And yes, recording we will happily make that available. Are there
Yeah.
any? Yeah.
There is a recording that's automatically on our YouTube channel after this that you can go and watch, and it's available all the time. And we did host another one in September of last year that is already on there. Maybe there were some different questions asked and answered, and you could also watch that one to see if you get more information.
Great. Thank you, Karen. Thank you for your efforts, and thank you efforts of communication with patients. And thank you for all the participants sharing very intimate details and just trying to help other women get the right treatment for themselves. Thank you for sharing.
Thank you, everybody. And I think the next one we'll do will be on fallopian tube recanalization, Gary. Seems
Brilliant.
like a new topic for us.
I agree. I think that'd be a great idea.
Yeah.
Thank you. Please look out for that, ladies, and thank you for participating. Happy to answer your questions afterwards. Please contact us on the details that are shown. All right. Bye-bye.
Bye.